Okay, everybody. Good afternoon and good evening. It's just about 1 minute after 6 o'clock here, so I think we will get started. Some people are still joining, but we'll just kick things off now. So my name is Sarah DeFeo. I'm the Vice President of Scientific Affairs and Programs here at Ovarian Cancer Research Fund Alliance, and I want to thank everybody for joining us today as we continue our webinar series for 2017 with this great presentation on PARP inhibitors with Dr. Ursula Matulonis. OCRFA's webinar series has been supported by Genentech, so a big thank you to Genentech for making this webinar and all of our webinars possible. So just a little bit about our organization. Ovarian Cancer Research Fund Alliance is the largest global organization dedicated to fighting ovarian cancer. We advance research to prevent, treat, and defeat ovarian cancer. We support women and their families before, during, and beyond diagnosis, and we work with all levels of government to ensure ovarian cancer is a priority. So before we get started, just a few housekeeping notes to go through. All listeners, you'll all be in a listen-only mode throughout the presentation. We should have some time for questions at the end, so if you think of a question as you're listening, you can type it into the Q&A box that you see on the right-hand side of your screen. I'll see the questions and I will select some to ask Dr. Matulonis at the end of the presentation. And there's no need for you to wait until the end. If you think of your question, you can just type it in as we go along. So a little bit about our speaker. We're really lucky to have Dr. Matulonis here with us today to do this presentation. Dr. Matulonis is Medical Director and Disease Center Leader of the Medical Gynecologic Oncology Program at Dana-Farber Cancer Institute and Associate Professor of Medicine at Harvard Medical School. Her research focuses on developing new targeted therapies for gynecologic malignancies with a specific interest in the genetic changes in ovarian cancer and how that can lead to rational drug selection. She's the principal investigator of several clinical trials and translational studies for ovarian cancer, and she serves on many professional and volunteer boards and committees, including the National Comprehensive Cancer Network Recommendation and Guideline Committee for both ovarian cancer and for the treatment of anemia, the Gynecologic Oncology Group Ovarian Committee and Quality of Life Committee, the NCI Ovarian Cancer Task Force, and for OCRFA, she's a member of our Scientific Advisory Committee, and in that role she spends a ton of time each year reviewing our grant applications and more. So she's a real leader in this field. She's an expert on PARP inhibitors, and she gives very generously of her time to the community that she serves. So let's get things started. So Dr. Matulonis, your presentation is up, and I will pass the mic to you.
That sounds great, Sarah. Thank you so much. Good evening, good afternoon to everybody. The only correction I'd make to Sarah is, it seems like a trivial point, but just because it takes like not quite a lifetime. Lifetime is too strong of a word, but I was promoted to full professor in the past year.
Excellent.
I know, exactly.
Congratulations, and my apologies.
I went, okay. You know, at getting promoted at Harvard is like, you can't believe it. But anyway, it happens.
It's a big deal.
Thank you so much. I don't mean to be a big deal out of it, but
no,
I'm going to leave it at that. Anyway, I'm going to continue on. So I am here to talk about, now I've got to get the, there we go. It works.
Yep.
The agenda. So the agenda for tonight, and I'm going to talk for about, I'm going to keep a close eye on my watch, probably like, Sarah, for 20, 25 minutes, something like that?
Sure. Sounds good.
Yeah, okay. And then certainly take questions, and this is really a high-level view, but I'm also going to insert kind of personal anecdotes from how PARP inhibitors were first developed and how the whole field really came about to now with 3 PARP inhibitors that have been FDA approved for ovarian cancer. And FDA is obviously the Food and Drug Administration of the United States. The parallel organization in Europe is called the EMA, European Medicine Agency, and thus far there's one PARP inhibitor approved in Europe, and that is olaparib. But we'll talk about that as time goes on. So here's the agenda, really talking about what are PARP inhibitors, what do they do, how do they work, which ones are available for ovarian cancer treatment. I've already given you a little bit of a difference between the U.S. versus Europe. A lot of the trials that have been done, and these trials really started back in 2007, so it's taken nearly a decade to this point. The first PARP inhibitor in the U.S. was approved in 2014, so I should think it'd take quite 10 years to be FDA approved, but pretty darn close. And then talking about some of the PARP inhibitor toxicities to wrap up. And again, these are really high-level slides, so if anything comes up specifically, please let me know. So just a few words about how these drugs work, how these agents work. So there are two types of nicks or breaks in our DNA, and they're either single-strand breaks, which is on the slide right now. You can see that the break doesn't cross through the DNA. And single-stranded breaks are felt to be sort of the more simple types of breaks to repair. And again, there are, loads of these breaks that occur during the day just because of, when the DNA is replicating, mistakes happen, sunlight, all those things cause breaks in the DNA. And how a single-stranded break is repaired is actually through, it's more complicated than this slide shows, but through PARP. So PARP is an enzyme, and it sets off something called base excision repair, or BER. And I always think of PARP, I describe it to folks as kind of it's like a first responder. It's like a first responder to a single-stranded break in the DNA. And it's really important that when it comes into action, which sort of it kind of drives over to the break, it hops on the DNA and then it hops off the DNA. So it kind of has to do its job really quickly. And then it brings along a whole host of other important molecules that kind of get this cascade of single-strand break repair, base excision repair going. Now, there's the double-stranded break, which is on this slide, and this is a crucial break. So if this break is not repaired, unlike single-stranded, so if the single-strand break doesn't get repaired, there are actually other patch-up jobs that the DNA can figure out. But for double-stranded breaks, this is a type of a break that if the DNA doesn't repair itself, the cell will fall apart and not survive. And there's also a very complex set of DNA repair mechanisms called homologous recombination, or HR. And there are several different pathways besides base excision repair and homologous recombination that repair. But those are the two main ones, and especially homologous recombination. If something's wrong with homologous recombination repair, that's a bad thing for a cell. So PARP inhibitors really take into account, and they work by this concept of synthetic lethality, meaning that you really have to have two events occurring simultaneously in order for the event to happen. So synthetic lethality, if you have one, meaning you've got, let's say, a single-strand break, but you use a PARP inhibitor, so therefore your PARP enzyme doesn't work, that's one event. But then the cell figures out a way of using homologous recombination to fix the break. But if you have both events, something wrong with homologous recombination and single-strand break repair, then you get cell death. So that's what happens here. PARP inhibitors exploit this concept of synthetic lethality. You've got the PARP enzyme that's there fixing the single-strand break, and with the PARP inhibitor, that inhibits the enzyme PARP. So thus, there's an increase in the number of double-stranded breaks, so single-strand breaks initially, then the cell converts those breaks to double-stranded break repair. And if there is a non-functioning BRCA protein, that's the second genetic event. So basically, a cell that has an underlying BRCA1 or BRCA2 mutation. And thus, homologous recombination is not working, and you get cell death. So that's the sort of the simplistic way of how cell death occurs when you've got synthetic lethality, meaning there's a PARP inhibitor on board, inhibiting single-stranded breaks, and you've got a non-functioning BRCA protein, which is important in homologous recombination. So another way of thinking about how PARP inhibitors work, kind of at the cellular level, is that, again, we just talked about this, and it inhibits the enzyme PARP. So the actual enzyme PARP is not able to do its functioning. And then something called PARP trapping. So as I mentioned earlier, PARP has to sort of climb onto that damaged DNA, and then it falls off. But if PARP gets stuck, so in other words, if the enzyme gets trapped onto the damaged DNA, that's a bad thing, and the DNA can't repair itself, also leading to cell death. So that's how PARP inhibitors work. So when you sort of look at papers that are saying, well, you know, this PARP inhibitor works this way, or, you know, the level of efficacy of the drugs, you look at how well the enzyme is inhibited, and then secondly, how well the drug causes PARP trapping. Because if the PARP gets stuck on the DNA, as I said, DNA repair does not happen. And this is a picture from 2005, and it really set the field off in terms of the excitement around PARP inhibitors. There were two simultaneous papers presented in the journal called Nature back in 2005. The bottom axis looks at the level of how much drug there is, so the concentration of the drug, and then the other axis, the y-axis, looks at how much of the cells are surviving. So where the red line is, that's a cell that has both copies of the BRCA gene not working. So in that particular cell, the BRCA or breast cancer gene, thus the breast cancer protein, doesn't form, or it's abnormal. And why is this important? Well, the BRCA protein is critical in homologous recombination, that second genetic event that's so important in synthetic lethality so that PARP inhibitors can work. So you can see that that particular cell is very sensitive to lower concentrations of a PARP inhibitor, whereas all the way on the right, where that blue line is, those are cells that have either one functioning copy of BRCA gene or both. So you can see that in those cells, the BRCA protein is present and functioning, and those cells are not sensitive to the PARP inhibitor until you get all the way out to the right, where you get loads of the drug, and finally you can kill that cell. Okay, so here are the four PARP inhibitors. There are other PARP inhibitors, but these are the four that are actively being tested in ovarian cancer or are FDA approved or both. So they're not in any particular order, but the top, I think I put them on this because they fit on the slide. But rucaparib, so I'll give you the trade names. So rucaparib is called Rubraca, olaparib is called Lynparza, niraparib is called Zejula, and veliparib, I don't think has a trade name yet, or at least I haven't heard it. It's called ABT-888. And the first three, rucaparib, olaparib, and niraparib, are all the most potent inhibitors of the PARP enzyme and are the best PARP trappers. Veliparib doesn't trap PARP as well, and it's a PARP inhibitor that is being combined with chemotherapy. But the first three, rucaparib, olaparib, and niraparib, cannot be combined with chemotherapy easily because of the overlapping bone marrow suppression. Now, there's another PARP inhibitor called talazoparib, BMN 673. I don't know if it has a trade name yet, but that's also, it hasn't really been, it's been tested a little bit in ovarian cancer, but it's mostly being used now in prostate cancer. But that's another very good PARP inhibitor as well. I just put this slide up because you can really see that of the different PARP inhibitors, rucaparib, olaparib, niraparib, and veliparib, each drug is metabolized a little bit differently. Secondly, medications that one may be taking might influence the PARP inhibitor levels, either increasing the PARP inhibitor levels or potentially decreasing the PARP inhibitor levels. There can be drug-drug interactions, so if you're taking a PARP inhibitor and a certain antibiotic or a certain cardiac medication, there may be interactions between those drugs. And then fourthly, each of these drugs has a very specific effect on transporter proteins that can lead to increases in something called the creatinine level, which you may know is a reflection of kidney function and liver function tests. So when this happens, when, let's say, the PARP inhibitor is blocking one of these transporter proteins, it may cause, the PARP inhibitor may actually cause an increase in the creatinine level in the blood or some of the liver enzymes. And one has to be cognizant of the fact that that is kind of a laboratory side effect of the PARP inhibitor, but doesn't necessarily reflect that, oh yes, kidney function is being disturbed or liver function is also being disturbed. So that's just something that your oncologist, the oncologist, has to be wary of. And I just put this up here because each of these drugs is different, so it's really important for physicians who are prescribing these drugs to be familiar with the package insert, the FDA package insert, where this information is easily and readily available. This slide talks about which drugs are now FDA approved for ovarian cancer. So olaparib was the first medication approved, and that was approved in 2014. The original intent of olaparib was to use it as a maintenance therapy, and I'll get to maintenance in a few minutes, but basically using the drug when somebody has a platinum-sensitive recurrent ovarian cancer, meaning somebody has recurrent ovarian cancer, it's platinum sensitive, you go back to a platinum doublet such as carboplatin paclitaxel, carboplatin gemcitabine, and then at the completion of that chemotherapy, use the PARP inhibitor to try to maintain that response to platinum. So I was actually part of that team that went to something called ODAC, which is a committee, an independent committee that gives advice to the FDA about whether or not a drug should be approved or not. And it was not a very good meeting. It was the first time that a PARP inhibitor the results were being presented to an FDA type of committee, and there were a lot of sort of misconceptions about the drugs and, just not fully understanding what an unmet need in ovarian cancer, that there hadn't been any drugs approved since 2006. So, but finally, at the end of that year, olaparib was approved as a treatment for women who had recurrent ovarian cancer, and those folks needed to have an underlying germline VRC mutation and had to have received at least 3 prior lines of chemotherapy, and that could include the upfront carboplatin and paclitaxel. So that was the original approval in December of 2014, and then most recently, just in August of 2017, so just a few weeks ago, olaparib was approved as maintenance therapy. So our original intent when we went to the FDA back in 2014, but now it's actually approved. And so the original olaparib approval was for the capsule formation. So the capsules were 50 milligram capsules. Folks would have to take 8 capsules in the morning, 8 capsules at night, so 16 capsules per day. Now that's been changed to tablet formation. So the tablets are 2 tablets in the morning, 2 tablets in the evening. So it's 300 milligrams twice daily. And that has been used as maintenance therapy. And I'll talk about maintenance, as I mentioned, in a few slides. And so for that, when I say biomarker, I mean like what test needs to be present in order to receive the drug. And there's no, it doesn't matter if somebody has a BRCA mutation or not. That's sort of been taken away. Rucaparib has the same type of a indication as olaparib once did, except that the FDA expanded the biomarker to a germline BRCA mutation. So in other words, a BRCA mutation, not just from every cell in the body, which is called a germline mutation, but something called a somatic or tumor mutation. So there are individuals who may not have a germline BRCA mutation, but may only have a tumor mutation, so a tumor BRCA mutation. And we know that both of those types of mutations, as long as they're considered deleterious, meaning when they are present, they make that BRCA protein not function as well. But as long as those mutations are deleterious, it doesn't matter if it's a germline mutation or somatic mutation, the cancer can respond to a PARP inhibitor. And then lastly is niraparib. That approval came in earlier this year, March of 2017, and this was using niraparib very much now to olaparib's maintenance, so using niraparib post-platinum after a platinum response in somebody who's got a platinum-sensitive recurrent ovarian cancer. And again, there's no biomarker here except responsiveness to platinum. Okay. What time is it? 6:23. I'm going on here. Okay. So this is a slide I tend to use very often as a presentation when I'm just talking to physicians, and I think it's a really important one. We know that there are different types of ovarian cancer pathology or histologies. The most common is something called a high-grade serous, and that's S-E-R-O-U-S. Probably 75%, close to that, a little bit more maybe, of all ovarian cancers, and I include peritoneal and fallopian tube in that as well, are high-grade serous carcinomas. So 50% of them have underlying DNA repair problems, meaning, as I mentioned before, homologous recombination. So something's wrong with repairing double-stranded breaks. And of that little cartoon on the right, the right of that cartoon, it says HR deficient. That stands for homologous recombination deficient, meaning the cell can't repair double-stranded DNA breaks properly. So 50% HR deficient, and you can see the reasons why. So, about 15% of cancers have women have, again, about germline BRCA mutations. Another few percent have just tumor BRCA mutations, and then there are a whole bunch of others. This is again, a very basic slide, but so 50% have some underlying problems. The other half, on the left, means HR proficient, meaning that homologous recombination is actually okay. The third bullet on this says BRCA1 and 2 mutations are neither necessary nor sufficient for response to PARP inhibitors. So I think that it really means that other underlying problems need to happen. So again, that concept of synthetic lethalities, and also the need to, 50% of high-grade serous carcinomas are going to be potentially responsive to PARP inhibitors. How do we make the other 50% responsive as well? And we'll talk about that. And I put on the bottom bullet, which is a very important one, and certainly that I talk about when I give talks, is that there's an international, basically not proclamation, but an international recommendation that all women with ovarian cancer, and as I mentioned, I pull in peritoneal or fallopian tube cancer into that, need to be tested. Oh, I didn't finish that sentence. It says all women with ovarian cancer or peritoneal or fallopian tube cancer, regardless of family history, histology, or age, should undergo or should be recommended for BRCA testing. I forgot to put the rest of that on there, sorry. But basically, any woman with ovarian cancer should undergo genetic testing, regardless of family history, age, or type of the cancer. So this is a busy slide, but it kind of gives you the studies that have led to some of the approvals of PARP inhibitors, and I'll just give you high points of these different studies. So the first one was a trial that was done a number of years ago, and it was looking at the PARP inhibitor olaparib, and it looked at two different doses, 400 milligram dosing twice daily or 100 milligrams twice daily, and this is using the capsule formation. And the criteria for women to come into this trial are basically they could have platinum-sensitive or resistant cancer. There's no line limit, but they did have to have a germline BRCA mutation that was considered deleterious. And what we found was that despite the fact that even though that the 100 milligram twice daily dose inhibited the enzyme PARP in blood cells, you really needed that higher dose to exhibit a clinical response. So the overall response rate was 33% for the higher dose and only 13%. So there is some level of dose responsiveness of these drugs. And again, this is using the capsule formation, which again, we don't use anymore. We're now using the tablets. The second study was by Stan K, and this was published in the Journal of Clinical Oncology, 2012, looking at, again, two different doses, now a little bit higher dose of olaparib, 200 versus 400, and PLD stands for pegylated liposomal doxorubicin, or Doxil. And it was interesting in this study, all three of those, so women were randomized to one of those three groups. All the women actually did pretty similarly in terms of the level of benefit from the PARP inhibitor or Doxil as response rate, or how long it kept the cancer in remission for. So the original thought was maybe that PARP inhibitors would work better than chemotherapy, but in somebody who has an underlying BRCA mutation, Doxil can work just as well. Karen Gelman's paper, published in Lancet Oncology 2011, showed that a PARP inhibitor can work not just in a patient who has a germline BRCA mutation, but in somebody who does not have a BRCA mutation. So that was an important observation. Bill Kaufman's paper, more recently published, really was the paper that led to the original olaparib FDA approval, showing good response rate and duration of response in women who had underlying germline BRCA mutations who had received at least 3 prior lines of treatment. And then the last two are phase 1 and phase 2 studies of the drug niraparib and then also the drug rucaparib, both showing response rates of, higher response rates in BRCA mutated cancer, but also response rates in non-BRCA mutated cancers. So what are some of the signals or biomarkers or tests or features of somebody that might predict for PARP inhibitor sensitivity? So we've already talked that the presence of a deleterious germline or tumor BRCA mutation can predict for an enhanced sensitivity to a PARP inhibitor. Now, there's another way of testing for sort of taking out the mutations, but looking at something called homologous recombination deficiency. And these are scars, genomic or scars to the DNA of a cell that might predict that that particular cell or cancer might be more sensitive to a PARP inhibitor. But as I've already noted, the FDA approvals thus far do not require these types of tests, so a lot of us don't do them. Some of the clinical biomarkers are the level of platinum sensitivity, and I'll show you some data around that, the number of lines of previous treatments, and then a special, and I mentioned this, about 75% of all ovarian cancer is high-grade serous histology. And that type of ovarian cancer gets pulled out because, as I mentioned before, 50% of those cancers have underlying DNA repair problems. But there are others. I mean, you can also find BRCA mutations or other problems within clear cell tumors, high-grade endometrioid. The types of ovarian cancers that tend not to be sensitive to PARP inhibitors are typically the low-grade tumors, so low-grade serous cancers, low-grade endometrioid tumors, and mucinous cancers. So this is data that a number of us pulled together of all of the single-agent olaparib studies in women who had recurrent ovarian cancer and had what would be considered a deleterious germline BRCA mutation. So again, what predicts likelihood of response to a PARP inhibitor? One, the presence of a BRCA mutation, the level of platinum sensitivity, and the number of prior lines of treatment. So on the graph on the right, the x-axis shows the previous lines of chemotherapy received, so from 1 up to 14. And on the y-axis is the overall response rate, or ORR, overall response rate. And you can see, so the black line is platinum sensitive, women with platinum sensitive cancers. The blue is platinum resistant, and then the pink or purple is everybody put together. So based upon this, and I think we pulled together 6 or 7 studies, that the more platinum sensitive the cancer is, the higher the chance of a response. So you can see that the black line has a better response rate than the light blue line. And then fewer numbers of lines of prior treatment also would predict a higher response rate. Okay, PARP inhibitors as maintenance therapy. 633, okay. So this is the other approval indication right now. So study 19 was published in the New England Journal of Medicine a number of years ago. And this was a randomized phase 2 study. So these were women who had mostly high-grade serous ovarian cancer, platinum sensitive, meaning that there was at least 6 months between their last platinum and then evidence of recurrent cancer. And they had to show continued benefit to a platinum drug. So they had platinum-sensitive cancer and then were treated with platinum again. And they were randomized 1-to-1 to either olaparib versus PARP inhibitor olaparib, or randomized to olaparib versus placebo. And this showed that the women who received olaparib had a longer time that the cancer remained in remission for compared to placebo. And this study really led to the EMA approval, so the European approval as olaparib maintenance in BRCA mutated ovarian cancer. And then now there have been 3 phase 3 studies of PARP inhibitor maintenance performed. And these are international trials. They're done both in the United States and Canada, in addition to into Europe, all showing evidence that the use of a PARP inhibitor post-platinum response keeps ovarian cancer in remission longer compared to placebo. And that's true of niraparib, which is called the NOVA study, SOLO-2, which is the confirmatory study after study 19 for olaparib, and then most recently, that was just presented a few weeks ago at a European meeting, ARIEL-3, showing the benefit of rucaparib in this maintenance setting. So there are also ongoing trials for women with newly diagnosed ovarian cancer that include a PARP inhibitor. So SOLO-1 is done, and we're awaiting those results. So those are women who have an underlying BRCA mutation, newly diagnosed. They finish up their upfront chemotherapy and were randomized to either olaparib maintenance or placebo maintenance. The second is called GOG 3005, and that is looking at the PARP inhibitor veliparib, either with chemotherapy or as maintenance or both. The PAOLA-1 trial is looking at bevacizumab alone or bevacizumab plus olaparib after chemotherapy has been completed. And then the PRIMA study, someone finishes up their original chemotherapy and are randomized to either niraparib maintenance or placebo maintenance. You remember I said that the PARP inhibitors that trap PARP the best, niraparib, rucaparib, and olaparib, you cannot put those drugs together with chemotherapy easily, and that's shown here that all of those three drugs, well actually all those two drugs, niraparib and olaparib, are being used after chemotherapy has been completed. Okay, so what are the known, what do we know about how PARP inhibitors, how do cells become resistant to PARP inhibitors? And we know that one of the main ways is that the cell then begins to repair DNA properly. So restoration of DNA repair, meaning that initially you have homologous recombination deficiency, but now you have homologous recombination proficiency. The cancer can now repair DNA. And that's something called the somatic reversion. So there are ways that the cancer cell, if there's a BRCA mutation present, making those cells more susceptible to a PARP inhibitor, that mutation can get fixed. So now the cell can repair DNA properly and it's fine. So it kind of resists the effects of a PARP inhibitor. And there's some of those, that's a main reason why some cancer cells become resistant to PARP inhibitors, because the genetic mutation gets fixed. Then there's something called epigenetic reversion of BRCA1 promoter hypermethylation. So basically, and this is a way of making the BRCA protein fixed again, is by something called hypermethylation. And again, this actually only interestingly happens with BRCA1 and not BRCA2. And then 3 is the presence of something called a hypomorphic allele. So there's maybe there's something wrong with the gene, but it still makes a little bit of BRCA protein, making the cell resistant to a PARP inhibitor. So some of the strategies that we're thinking about for either cancers that are upfront, we know are not going to respond as well to a PARP inhibitor, or in the setting of a cancer that's been, shown a PARP inhibitor. So for a woman who's been on a PARP inhibitor, but then the PARP inhibitor, or then the cancer starts to grow through the PARP inhibitor, it's taking that cancer that's HR proficient, meaning it can repair DNA, to something called HR deficient, where the DNA repair mechanism is broken. And we're looking at that through combinations. So there are many combinations. Many institutions, including ours, are looking at either preclinical, meaning either in a test tube or in a mouse. That's what preclinical means. And then clinical investigation, meaning clinical trials, that include a PARP inhibitor plus something else that basically tries to make that cell more sensitive to a PARP inhibitor. So there's something called CDK1, CDK12, PI3 kinase, and so multiple different ways of tricking the cell into thinking it should be sensitive to a PARP inhibitor. And these next two slides tell you some examples of these PARP inhibitor combinations and then their clinicaltrials.gov number. So the top one, olaparib and cediranib, are studies that we actually did at Dana-Farber. One of my junior colleagues, Joyce Liu, back in 2009, she received NCI funding to put these two drugs together. Olaparib, as you know, is a PARP inhibitor, and cediranib is like an oral bevacizumab. So it blocks angiogenesis or new blood formation or new blood vessel formations of the cancer, and found that that combination worked particularly well in in a woman who had recurrent ovarian cancer but did not have a germline BRCA mutation. So that combination has now led to several phase 2 and phase 3 studies that are ongoing. I've listed here 3 studies that are combining PARP inhibitors with anti-angiogenics. The bottom part are combining PARP inhibitors with immunotherapy agents, so mostly immune checkpoint blockade agents such as pembrolizumab, durvalumab, atezolizumab, but there are also other drugs called CTLA-4 inhibitors like tremelimumab and durvalumab. So all those studies are ongoing, and we await those results. And then a whole host of other trials that are looking at either potentially combining PARP inhibitors with other molecules that inhibit other mechanisms of DNA repair, such as, where we got here? So the WEE1 inhibitors, AZD1775, ATR inhibitors. So WEE1 is actually important for cell cycle control. So if there's something wrong within the DNA, it has to get repaired, and it goes through a kind of a halt in the cell cycle growth, and the breaks and whatnot get repaired. So WEE1 is actually very important in regulating the cell cycle. ATR inhibitors, so the whole host. So there's a lot of work going on in PARP inhibitor combinations. So just to finish up, I said I'd talk 25 minutes, and I've babbled on for close to 45. So I'll talk a little bit about PARP inhibitor toxicities, and some of these are across all PARP inhibitors, and some of them are somewhat specific. So for gastrointestinal toxicities, they are seen with most PARP inhibitors, and these could include nausea, vomiting, decreased appetite, diarrhea, constipation, abdominal pain, upset stomach, and a funny taste in the mouth sometimes. These side effects tend to improve over several weeks after taking the medication. So you can take anti-nausea medicines, drugs that alleviate constipation, but eventually most of these side effects should wear off or at least improve. The other toxicities that are seen are hematologic, meaning bone marrow suppression, fatigue, as well as others. So we can see drop in blood counts, red cells, white blood cell count, platelets. And the FDA package inserts have specific recommendations on how frequently blood counts should be checked when somebody starts a PARP inhibitor. There's a small risk, about 1% to 2% of AML. AML stands for acute myelogenous leukemia. AML or MDS, MDS is the other kind of pre-leukemic syndrome. It's called myelodysplastic syndrome. This was one of the side effects that derailed the initial presentation that we made to ODAC, and it's an important toxicity. It has been shown that in randomized trials of either placebo or a PARP inhibitor, that risk of AML is pretty much equivalent between both groups of women, either those getting the PARP inhibitor or those getting a placebo. So I still think that there's probably a little bit of a higher risk of AML. I always mention this to my patients, but it's low. Fatigue, yes. And then there's some side effects that are specific to certain PARP inhibitors. So high blood pressure, elevated heart rate, and palpitation seems unique to niraparib. Liver function test elevations, which can be transient because of that transporter protein problem I mentioned before, seen with rucaparib. You can see serum creatinine elevations that's not related to decreased kidney function, but is related to that renal transporter blockage of the PARP inhibitor is seen with olaparib and rucaparib. And then pneumonitis, so lung inflammation, can be seen as well. So it's important that if anyone's developing any kind of shortness of breath that you make sure with a chest CAT scan that there's no pneumonitis. So some concluding thoughts. I think PARP inhibitors right now are one of the most, if not the most exciting new class of agent for for the treatment of potentially all aspects of ovarian cancer, either as single agents or in combination. PARP inhibitor combination testing has challenges. As you can see, there's really a lot of different combinations already in testing. So how do you decide preclinically which combination is promising enough to move forward with? What are potential drug-drug interactions that occur between the PARP inhibitor and the other drug you're combining it with? And certainly this is not necessarily evident in a test tube or a mouse, but has to be tested in a human. How will the combination receive regulatory approval, such as FDA or EMA approval? And what happens if the agents are from different companies and getting companies to work together? PARP inhibitor testing is underway from phase 1 to phase 3 studies, and I think the PARP inhibitor field has really brought together teams of physicians and teams of scientists, experts in DNA repair from a scientific standpoint, laboratory scientific standpoint, ovarian cancer clinical trial design, which trial designs make the most sense to get medications tested, make sure they're efficacious and safe, and then as quickly as possible into our patients. And then again, kind of this rational phase 1 study design. So I am done with my slides, and Sarah, I am happy to answer any questions.
All right, wonderful. Thank you so much. That was terrific. Ton of good information. So that was wonderful. We have a ton of questions coming in. We will get to some of them in the next 15 or so minutes. I do want to tell everybody, because a couple of people have asked, yes, this is being recorded, and we will post the recording as well as the slides on the OCRFA website probably tomorrow. We do that with all of our webinars. So I know there's a lot of information, so you can always go back and listen again. All right, so to some of the questions that came in now, and some of you also submitted questions when you registered, which I did take a look at. So some of these, Dr. Matalonis, were touched on, but I think they're kind of worth getting into again. Sure. So we have several questions around some of these issues. So how does one decide which PARP inhibitor to use?
So I think I will fall into the FDA guidelines. So I think that, we've already talked about olaparib and niraparib being now approved as maintenance therapy post-platinum in platinum-sensitive setting, as long as a woman her cancer is sensitive to platinum. And I think the physician has to decide with his or her patient which drug you're going to choose. And, it could depend upon drug-drug interactions. It could depend upon underlying previous medical problems, et cetera. So that's how I make the decision. And then the other two, so olaparib, which is also being used as maintenance, you can use that as primary treatment along with recombination. And they have very specific FDA indications. Olaparib is for underlying germline BRCA mutation, at least 3 prior lines. Recombination, germline or somatic mutation, at least 2 prior lines.
Okay.
I'm happy to talk more. I think it's a whole huge conversation, but
yeah,
that's how I make the decision.
Okay, that's helpful. And just to clarify for people, so for folks without BRCA mutations who know that they know for sure that they don't have a BRCA mutation, what would you say to them in terms of PARP inhibitors?
Right.
What's their option?
So there's a study, and I mentioned this as GY004. It just recently closed. I think it just closed over the weekend. And it's a randomized trial for women who have platinum-sensitive recurrent cancer to either the combination of olaparib, cediranib, so that's the trial with olaparib, PARP inhibitor, cediranib, the oral anti-angiogenic agent, versus a platinum doublet, so carboplatin, gem, carboplatin, paclitaxel, etc., versus olaparib. And we know from Dr. Gelman's study that I also mentioned that there is definitely a level of responsiveness in a patient who does not have a BRCA mutation, but it is a little bit lower than if she had a deleterious mutation. And we also see that through the maintenance studies, all three of them, Ariel 3, NOVA, and now SOLO 2. Well, actually not SOLO 2, never mind, because SOLO 2 was only in BRCA-mutated cancers, but Ariel 3 and NOVA, to a little bit more extent in the NOVA study, that even in the setting of not having a BRCA mutation, you know, there's responsiveness to the PARP inhibitor. As long as that the cancer is a high-grade serous cancer, kind of a high-grade cancer, and responsive to platinum. So the maintenance studies distill a woman, a patient, who's going to have the most benefit. She has a high-grade serous cancer, she's got initially platinum-sensitive cancer, and then to the most recent chemotherapy doublet, platinum doublet, there's also sensitivity. So you're really pulling out a cancer that is going to have the highest efficacy or responsiveness to a PARP inhibitor.
Okay. You've mentioned throughout that this is really only, or the studies have been specifically focused on high-grade serous ovarian cancer.
Yeah, right.
We've had several people ask about low-grade serous cancer. And do we have any reason to believe this is promising? Will studies be done? What's your take on that?
Yeah, no, it's a really good question, and again, it all has to do with that tricking of making a cancer cell that has normal DNA repair into one that has abnormal DNA repair. And there had, for example, one of my colleagues, Panos Konstantinopoulos, is doing a trial of a PARP inhibitor plus a heat shock protein inhibitor, HSP90 inhibitor. And right now, during the phase 1, when we're trying to get the dosing as best as we possibly can, any type of a histology, a woman with any type of ovarian cancer histology can enter into that trial. So we'll get some indications about how PARP inhibitor combinations, at least of those two drugs, have in lower grade tumors. Again, low grade tumors, they're not as platinum sensitive, but they're more hormonally sensitive. So I think right now that's still kind of a field of study.
Got it. The use of PARP inhibitors versus Avastin for maintenance. We've got questions about this. What are the factors that people should be considering if they're thinking about maintenance therapy?
Right. So I think, if the studies that have looked at Avastin or bevacizumab maintenance, something called the OCEAN study, carboplatin gemcitabine versus carboplatin gemcitabine bevacizumab, and then the Gynecologic Oncology Group study 213, which was carboplatin paclitaxel versus carboplatin paclitaxel bevacizumab. So it was the latter study that showed that not only if you added bevacizumab to carboplatin and paclitaxel do you keep the cancer in remission longer, there's also a hint of a suggestion that someone might also live a longer time, have a better overall survival. But you can see that not everybody wants to use paclitaxel again. The maintenance studies, if there's going to be a benefit from maintenance Avastin, that Avastin has to be given with chemotherapy and then by itself after chemotherapy is finished. So this is a decision that the patient and the doc have to make up front initially, because you need to put the whole point of the Bev benefit is with chemotherapy and then as maintenance alone. So if somebody starts carboplatin gem doesn't start Avastin, you know, the study doesn't, the results don't support using just Avastin as maintenance. So if you start with a doublet without bevacizumab, then that's where PARP inhibitor maintenance can come into play. I think what we don't know yet, and I'm definitely not doing, and is combining a PARP inhibitor with Avastin.
Right.
There's really no results out at all on the, you know, safety of that we know, but the question is the efficacy.
Right. Okay. Several people asked if you're on one PARP inhibitor and it's not working out well, no good results, can you switch to another one?
Yeah, I've been asked that as well. Technically, if one of the three main PARP inhibitors at their appropriate doses is not working, then it seems kind of unlikely that switching to another one would be okay. Now, that said, there's really no trial data to support doing that or to not support doing that. So we don't really know. I guess the only time that I would think about potentially switching from one to another is if for some reason a woman could not tolerate a certain dose of a PARP inhibitor, or if she was having some, you know, toxicity or side effect that made you stop the drug earlier than you would have, then I would feel okay about switching to another one.
Because you mentioned the dose, we had a few questions about the efficacy of these drugs through dose reductions, which we know is quite common with PARP inhibitors as you take them. So people want to know, are they still as effective if the dose is reduced, because those dose reductions are common?
Yeah, no, it's a good question. So I mentioned already that with the original olaparib capsule formation, which is being phased out, that the higher dose was better than the lower dose tested. So there definitely is some evidence of a dose response, but also it depends upon how somebody takes it. Now, with food, without food, although most of them can be taken with food. Drug-drug interactions, are you taking another medication that might lessen the concentration of the PARP inhibitor in the blood or enhance it, so make the side effects worse? So the doses, you know, the FDA has got it square in their package insert what the doses are. So for niraparib, it's 300 milligrams once daily. Rucaparib, it's 600 milligrams twice daily. And then now olaparib is 300 milligrams twice daily with the tablet formation. So I think there are definitely dose reductions that are built in. So for niraparib, it's 300 down to 200, down to 100. Olaparib, you can use different 100 milligram tablet permutations, and then with rucaparib, you can also dose reduce too. So if you have to dose reduce, you have to dose reduce. I guess there is a certain point when you go too low and that efficacy will be lost. So that has to be balanced with the level of side effects.
Now, in the PARP inhibitor trials, were dose reductions built into those trials?
Yes.
They were,
correct.
Okay. So it's reasonable for a patient to assume that that she may reap some benefit, just as those trials showed, even if her dose is reduced.
Yeah, I would agree.
Okay. Got it. Do PARP inhibitors cause hair loss?
So, good question. The three that are on the market right now typically do not. The one that does cause the one PARP inhibitor that does cause hair loss is talazoparib, or BMN 673, and that is one of the most potent PARP inhibitors. So there have been reports of hair loss. I mean, I think, you know, I've definitely heard of some folks saying there's hair thinning with any of the three that are on the market, but it should not cause, you know, none of these agents, with the exception of talazoparib, cause hair loss. So no.
Great. Okay, this will be the last question, I think. You talked a lot about the indicators of likelihood of response. A few people asked, how do I know if my PARP inhibitor is working?
Well, if you're on maintenance, the maintenance PARP inhibitor, you'll know it's working as long as the CA-125 is stable and or some kind of imaging, either CT, PET, or MRI, also shows that the cancer remains in remission. For a PARP inhibitor as primary treatment, same really, will be the CA-125 along with imaging. Sometimes the CA-125 is not always 100% accurate, so I typically will use some type of radiographic imaging in there as well.
Okay.
Every few months, every few weeks, every let's say 2 to 3 months, just to make sure that the cancer remains kind of in check or regressing.
Mm-hmm. Okay, our hour is up, so I think we will end it there. I'm sorry we didn't get to everybody's questions. We had a million questions. But I want to thank you again, Dr. Matulonis, for the presentation. I want to thank everybody for calling in today and listening. As we wrap up here, once the event ends, a survey will pop up on your screen, so please take a few minutes to fill it out. Your feedback is always really helpful to us, and it's helpful for us to know any ideas that you have as we put together future webinars. And again, this has been recorded, so we will email out a link to the recording probably tomorrow. And for more information about OCRFA, you can always visit our website, which is www.ocrfa.org. So thank you, everybody. Thanks again, Dr. Matulonis, and have a good evening.
All right, my pleasure. Take care.
Thank you.
Bye, Sarah.